So my name's Dipa Jayaseelan. I am one of the neurology consultants here at the National Hospital for Neurology and Neurosurgery. I think I pretty much know all of you. I will have met you all at some point. So I'm just going to start off by introducing the day, just doing a quick introduction about muscle channelopathies, a few housekeeping rules and bits and pieces, and then we'll get started. All right. So hopefully that's displaying. Brilliant. All right. So this is the program for today. We might move things around a little bit just to make things fit a bit better for you. So we're going to start off with me just kind of introducing today and an overview of muscle channelopathy. So we're all on the same page, though I see a lot of you are our usual regulars that come for these things. And then I'm just going to swap round because it's very boring to listen to me continuously for an hour. So instead of having me for an hour, I'm going to get Dr. Nagendran to talk about neurophysiology after me, and then I'll talk to you about navigating different stages in life for muscle channelopathies. Then we're going to have a coffee and comfort break just out in the foyer here. Then Dr. Vino is going to talk about research updates. We're going to talk about challenges in paediatric channelopathies with Dr. Munna, our paediatric consultant. Our two geneticists are here, so they're going to talk about genetic testing. And then we'll have lunch. So lunch will be again outside in the foyer. And then we'll finish off kind of in a more interactive set of sessions. So talking about lifestyle management. I think Sarah's going to do a bit of Pilates, I'm hoping. A Q&A session, and then we'll do our breakout groups. Okay. So just to give you an overview, the aims for today, the idea is just to give you an overview. We'll start off with a bit of an overview about channelopathies. We're going to talk throughout the day about tips and tricks for living with a muscle channelopathy. The idea is to try and give you some lifestyle management advice, update you on what research we're doing and what things have been happening, and then give you an idea about what happens when you come to see us in clinic and any new tests and things we're doing. And the most important thing is that we want to give you the opportunity to ask questions, to chat to each other, and to meet other people who have the same condition as yourself. And that's what the breakout sessions are really for. And your views are really important to us. So please, at the end, we're going to give you an evaluation form. You can do it online or you can do it on paper, whatever's easier for you. And just tell us what you think about the service, about today's event, and what things we can do better for you, what things worked really, really well. Okay? So just a warning before we start. You all got slightly different conditions. You all have slightly different experiences of all of this. And so your experience may be different from other people's. We're going to give you a general overview of what we see commonly, and it may not be quite the same as what your experience is. But we're trying to kind of cater to everyone here. So we're trying to make it as individual as we can, but with caveats that it will be slightly different for each of you. Because we have both patients with myotonia and patients with paralysis, there are going to be a variety of things we talk about, and we're going to try and talk about each thing individually and equally, but there will be some bits that aren't relevant. And we're not going to try and cover everything. We're never going to manage that. We try and make it slightly different every year, so you get a little bit of everything each time and something slightly different each time you come. But if there's anything specific you want to ask us, we have the Q&A session at the end, and hopefully we'll be able to answer any questions then as well. All right, so I'm just going to go through a little bit of an overview about who we are and what we do, and a little bit about muscle channelopathies, just so that everybody knows where we're starting from. So as you probably all know, we run the UK channelopathy service here, and we essentially look after the whole of the UK. Primarily England, just because of the way funding has changed, but we also see lots of patients from Northern Ireland, from Wales, from Scotland. So the whole idea is that we are an access service for everywhere. And we're centrally funded, so the money for our service does not come from the local area, it comes from NHS England, which means that any GP can refer into our service, any doctor can refer into our service, and allied health professionals can also refer in. So you're not restricted to come in and see us in the same way as other services are. The idea is that we try as much as we can to provide you with a one-stop service where you come in for your assessment. We try and do as many of the tests that we can on the day. We do the neurophysiology, which Dr. Nagendran is going to talk to you about. We do the genetic testing, with who our clinical scientists are going to talk about. And we also have a functional expression service, which basically means that if we're not sure what your genetic problem is doing to your channels, we can try and understand it better in essentially in a test tube kind of setting. And then, of course, we offer treatment, and we're trying to make sure that you all have access to all the treatments that are available, and some treatments that we're not sure about yet. The main conditions we cover, you can see it on the slide. We cover patients with myotonia, patients with periodic paralysis, and there are lots of different forms. You can see there are a lot of different conditions, and I'm just going to talk about each of those in a little bit later on. So this is the team. So most of us are here today. There are one or two people who have not been well enough to come, but you'll all know Professor Hannah and myself. So we run the channelopathy service together here. And Dr. Vino, who is our newly appointed consultant neurologist that started with us. She was our clinical fellow before, and she has stayed on as a consultant. So you'll be seeing, usually in clinic, you will probably see one of the three of us. If you're being seen at Great Ormond Street, you'll see Dr. Munnett. She's our paediatric neurologist, and usually it'll be me and her seeing any of your children in the clinic. And then if you have any neurophysiology tests, so any electrical tests, Dr. Nagendran will see you for that. And then Dr. Merva Assad is our new research fellow, who you probably, quite a few of you have met. If there are any research things going on, you probably will be talking to her on the phone about that. So we have our specialist nurses. We have Natalie and Albert. Unfortunately, they're not here today, but they're the ones who probably call you up for your medication appointments, to check how you're doing. They're the ones you're going to contact if you're having problems in between appointments. And on the paediatric side, we have Sean Craig and Emma Scott, who do the equivalent role. So on the physiotherapy side, we have Sarah Holmes, who I'm sure most of you have met and you'll see around today, who's our main specialist physiotherapist. And on the paediatric side, we have Nicola Burnett, who does the same role there. And then we have our research nurses, mainly Ivona, and Louise helps as well. They're the ones who contact you in between appointments to ask you to sign our consent forms if you want to be part of the different studies. So those are the putting faces to the names. And then you will have seen Jean outside checking you all in. So she is our invaluable secretary who basically runs this service from the back room and makes all your appointments and makes sure that your appointments are moved around as you want it. And she's phenomenal. And if you have any questions about your appointments, she's the person to contact. And then Jackie oversees things. And then on the genetics side, we have Richa and Gary sat down here. So they're the ones who, when your DNA is sent to the lab, they're the ones who look at all the results. They interpret it. They understand it. They basically inform us what everything means when we all sit down in a room and try and work out exactly what's happening with each of you. And then finally, we have Rupi, who is our electrophysiologist. So he's the one sitting in the lab looking at those unusual changes in your genetics and trying to understand them. All right, so that's the team and just gives you an idea of who we all are. And now I'm just going to talk to you about muscle channelopathies in general. So I'm just going to talk about what is a muscle channelopathy, what are the different types. I'm not going to spend too much time on investigations because I'm going to leave that to Dr. Nagendran to talk to you about that after me. And very briefly about treatments because Dr. Assad's going to talk to you properly about treatments a bit later on today. So what is a channelopathy? What is this thing that we look after and that affects you all? So it's basically a condition that's caused by one of your ion channels. So in other words, one of your channels is to do with how the ions flow into your muscle usually. One of those is not working properly. And why is it not working? Well, it's not working because there's a mistake in the gene. So there's a mistake in one of your genes that means that your body is not making the channel as it's meant to. So it could be that it's just not making it at all. It could be that it's making it, but it's not working correctly when it is produced. And what happens is, if that channel's not working properly, we don't get the signals that we need to get from our nerves to our muscles. And therefore, you end up with your symptoms. And so what are the different types of muscle channelopathy? Well, there are two main groups that we see in our clinic. And so you'll either fit into the group of non-dystrophic myotonias, in other words, those people with myotonia congenita, those people with paramyotonia congenita, sodium channel myotonia, and where you have predominantly stiffness, so what we call myotonia. And then on the other end of the spectrum, we have those patients with episodes of weakness. So those with types of periodic paralysis, that could be hyperkalaemic periodic paralysis, hypokalemic periodic paralysis, or Andersen-Tawil syndrome. And so basically, all of you will fit into one of these two groups. You'll either have the mainly myotonia at one end or the mainly episodes of paralysis at the other end. But what I'm sure you all know better than we do is there's a lot of overlap between the two. So a lot of people will get paralysis and a bit of stiffness, or stiffness and occasional paralysis. So what we see is a huge spectrum between all of you, and that makes you understand why the experience is so different for each of you. So what's happening? Where's the problem when you have a muscle channelopathy? Well, we talked about it being a mistake in the gene, but what gene has the mistake basically tells you what kind of symptoms you're likely to experience. So if you have a mistake in your chloride channel, that tends to give you myotonia, so predominantly stiffness and difficulty starting to move. You might get some weakness, but that tends to be much, much, much rarer in those conditions. Now, if you have a problem in your calcium or potassium channel, then that's going to give you episodes of paralysis, and that's going to be the main problem that you have, these episodes of weakness. Now, if you have a problem in your sodium channel, well, this particular channel is really tricky because patients can get stiffness, they can get weakness, so myotonia or paralysis, or they can get both, and often people change as they change in life. Often the predominant symptoms they get, that changes too. So if you have a sodium channel, you kind of tend to be in the middle of the two groups. So what is the actual problem? Now, this is the only really technical picture I'm going to show, and it's for those of you who like a bit of technical information on these things. But essentially, the problem we have is in one of these channels that you can see down around here. So when we go to catch a ball or to throw something or to move, we're sending an electrical impulse from our brain into our nerves, which sends a signal into your muscle. And you're telling your muscle to move, to contract. And what happens is, if one of these channels is not working properly, if, for instance, it's the sodium channel, then sometimes what happens is the channel won't hear the response properly, won't hear that signal correctly. So when you go to move, you kind of get stuck because you're stiff. And then if you say, for instance, have a problem with your calcium channel or your potassium channel, that channel's leaking. It's not allowing the signal to come through correctly. So when you go to move, you feel weak. So that's basically what's happening when your channel is not working. So now I'm going to talk about the different symptoms that you all experience in their different forms. So what exactly is myotonia? We talk about myotonia a lot for those of you who have myotonia. And for most people, the primary problem is stiffness. And that tends to be what most people's experience of myotonia is. It tends to be, technically, it's that difficulty relaxing the muscle after you use it. So that first impulse, that first signal that you're sending to your muscle, telling it to contract, that one works. That goes through and makes the muscle contract. But the signal to make it stop, the signal that's there to say, stop contracting, stop moving, that's not working properly. And so you feel stiff, your muscle stays contracted, it doesn't relax. And that's why you get the stiffness. So lots of people talk about feeling stuck when they first start to move. They kind of get stuck in one position because they're telling the muscle to relax and it's not listening. And as we said, the experience is different for everybody, but most people talk about stiffness and locking and cramping, and some people also get pain alongside that. When we see myotonia, all of the conditions we see, the myotonia affects skeletal muscle. So in myotonia, we don't see it affecting your heart muscle. We don't see it affecting your uterine muscle or your gut muscles because those are different types of muscle and they don't have the same channels in them. So this is a problem in your skeletal muscle, the muscles you use to move. Now, which muscles are most affected depends on the type of channelopathy. So if you have myotonia congenita, you're going to have a different set of muscles affected from if you have a sodium channel problem, a paramyotonia congenita. So where the mistake is in your gene really, really matters to how you experience these conditions. Okay, so those are the myotonias. That's for everybody with myotonia. But what about episodes of paralysis? Because I know a lot of you have periodic paralysis or episodes of paralysis, and that can be with your hypokalaemic periodic paralysis, hyper, or your Andersen Tawil syndrome. So with periodic paralysis, these are attacks of weakness. That's what we mean when we talk about it. They're attacks of weakness that tend to come and go, and that often is the first symptom that patients get with periodic paralysis. And so why does that happen? It happens because the muscle is not receiving the signal correctly. Again, it's the same problem, the muscle's not receiving the signal, but it causes a different issue because that channel is not listening at all from the get-go. So it's not hearing that initial signal to contract. So your muscle's not contracting, it's not working. And so it's weak. Now, the thing about channels are, channels open and channels close. So most people, especially when they first start out having symptoms, most people don't have the symptoms all the time because the channel's not being used all the time. So that's why you get the episodes of paralysis rather than necessarily being weak all the time. And so your triggers for what makes you weak will vary depending on which channel is not working properly. So for instance, if your calcium channel isn't working properly, then usually if your potassium level is low, that's going to be much more likely to trigger you. Whereas if it's a problem in your sodium channel, if your potassium level's high, that's more likely to trigger an attack. And patients will find they have particular triggers for food, and for most people, if they overdo exercise or overexert, that's much more likely to trigger an attack than anything else. In between attacks, patients usually don't have any symptoms at all, but that can change and it's different for everybody. All right, so I'm just going to very briefly talk about the key muscle channelopathies, all the different conditions that you all have. So myotonia congenita is probably the commonest condition that we see in the clinic, and it's a problem with your chloride channel not working properly. Okay? And patients predominantly get myotonia, and the symptoms tend to be worse when you start to move. So that sat in these chairs and you're going to get up to go for the break, that's when you're going to be your stiffest, I'm sure. But you find that the stiffness gets better the more you do. So the more you warm up, the better you are. Now, depending on the type of myotonia congenita, the legs are often worse than the arms. That's not always the case, but most people find that their legs and their back are worse than their arms. And the time to be really careful is when you suddenly start to move after you've been sat still or not doing anything for a long time. And some people do get weakness as well when they first get up, when they first start doing things. And then we have the paramyotonia congenitas, where the problem is that the sodium channel isn't working correctly. And so in those people, they tend to have primarily myotonia, but they can also get some weakness and some paralysis. That tends to be rarer, but it definitely happens. And they tend to find that their worst affected area is their face or their eyes, and much, much more cold sensitive than anybody else. So in the winter, their face and eyes are really, really badly affected. In the summer, some people don't even notice it. So there's a real difference between these conditions. And they tend to be much worse the more they do. So then we have the hypokalaemic periodic paralysis, and that's usually a problem in the calcium channel. Sometimes it can be a problem in the sodium channel, and it's to do with the way that those channels are leaking. So they don't respond properly because they're leaking. And these patients have episodes of weakness usually triggered by a low potassium. And the attacks tend to happen in the middle of the night or first thing in the morning. They wake up weak, and they can last from several hours to days. And their triggers tend to be eating that massive Chinese meal just before you go to bed, or a huge pizza with loads of chips, and then you go to bed. That tends to be the thing that triggers most people. But also strenuous exercise. So you go play your football match, have a load of pizza and beer, and then go to bed. The next morning you're much more likely to be weak. And then we have hyperkalaemic periodic paralysis, where patients have their sodium channel not working properly. So this is triggered usually by high potassium, though it can also be triggered by normal potassium levels. And usually the attacks are briefer. That's not always the case, but usually the attacks are briefer. And they can affect just one limb, but we have lots of patients who have whole body weakness as well when they have really severe attacks. But for this one, it's the potassium that tends to trigger them. And rest after exercise. So they play that football match, they're fine immediately afterwards. They go and sit down and then try to get up, and then they feel much weaker. So it's the rest after the exercise. And finally, Andersen-Tawil syndrome. So this is a slightly different condition because the gene that's affected in this condition is a potassium channel, but that potassium channel is not just in muscle, it's also in your heart and it's in your bones. And so patients get not only problems with episodes of weakness, which can be triggered by high potassium and low potassium and normal potassium levels, but also they can have heart problems. So it's really important to have your heart checked every year, and usually we'll tell you this in clinic all the time. We will always check whether you've had your heart checks done. And some people will have changes in their hands. You might have smaller hands. You might have a slight difference in your jaw size and things. And that's just because that gene happens to be expressed in your bone as well. So I know I'm running out of time, so I'm just going to very briefly talk about treatment because I know Dr. Assad is going to talk about it. But I think if there's one thing I say more than anything else is to try and avoid your triggers. Okay? And you will know what your triggers are because you've all been living with this for such a long time. You'll tend to know what the things are that make you more likely to have an attack of stiffness or weakness. But lots of people find that a change in temperature will trigger them. So trying to keep your temperature even, and particular foods will trigger them, and most people find that strenuous exercise will trigger. So trying to minimize that as much as possible. And then with myotonia, we have a number of different treatments available. We've got mexiletine and now lamotrigine, which we're using more and more. And Dr. Vina will talk about the big trial she's just finished. And there are other treatments like magnesium, carbamazepine, phenytoin, acetazolamide, quinine. Just ask us in clinic. There will always be options that we can offer you. And then with periodic paralysis, well, it depends what type you have, what we give you, but most people will respond to acetazolamide. If you have hypo, PP or Andersen Tawil, we might suggest potassium supplements. And sometimes we'll suggest potassium-sparing diuretics. Those push up your potassium level, basically. And then in hyperkalaemic periodic paralysis, again, acetazolamide is very effective, but thiazide diuretics can be used. We're being a bit more careful about that because if you drop somebody's potassium too low, whatever type of periodic paralysis they have, it can trigger an attack. So it's really important. The couple of take-home messages I'll say is attacks feel different to different people, and therefore it's really important to do what works for you, not necessarily what's working for everybody else. We have to be really careful not to go too high on your potassium or too low on your potassium because that can cause other problems. But if you have an unusual type of attack, which is much more severe than usual or different from your usual attack, if you tell us about it, then we can have a look and see why has that attack been different? What was different about that? And have a look at your potassium levels. All right, so I'm going to stop there because you've listened to me droning on for too long. If you want any more information, we have a website. That's the website address. There are QR codes up in the hallway as well. And a lot of what we talk about today will be on there, a lot of our leaflets and things. So please go there. So I'm going to stop there and I'm going to let Dr. Nagendran take over if that's all right.